thank you for your attention.
Thank you, Samuel. And the next speaker is again Frank Coblentz, and the title of his talk is Framework for Evaluation of Novel Latent TBI Test. Frank, get a glass of water.
So good morning again. So you may be wondering, why do we see the same guy? And that's because Sandra Kik, my colleague at KNCV, who did much of the writing and thinking for this, is unfortunately unable to come to the conference, so I'm sort of stepping in for her. And this is a presentation of the guidance document that is under development. And again, this is my conflict of interest statement. Sandra emphatically told me that she has none. So why do we need at all an evaluation framework? Because we don't have it for any other test. Well, I think it is important because thus far, if you look at the history of evaluation of IGRA, there have been all sorts of studies done, and it's a bit of a jungle in terms of what kind of studies have been done and what kind of outcomes, what kind of comparisons. And in the end, if an expert group has to sit down and come to a yes or no with regard to endorsement for such a test, it probably needs to have some guidance as to what is, as we might say, admissible evidence for that process. So that's number one. And two, of course, once we have established that, it is important to inform manufacturers, researchers, and research funders about the types of studies that are required for WHO endorsement. We don't want money and time being wasted on studies that in the end don't really matter. So which test should we concentrate on? Now, we've already sort of seen this. We can think of the classical LTBI test, whatever that may be, TST or the current IGRA, persistent infection test, incipient TB test, or active TB test. This is basically what they do. And for this document, we concentrate on a test for incipient TB because this is expected to have a high predictive value for incident TB disease, as I already mentioned, a rule-in test. And you've already seen this, why it is a rule-in test. Probably we are looking at a period of 12 to 18 months. If you look at the various studies that have been done, it has been difficult to delineate epidemiologically yet, but that's probably the period that you'll be looking at. So this is 12 to 18 months is basically this period. It may, as I already said, may have low sensitivity depending on when the test is done, so it may need to be repeated, and Samuel also mentioned that. And it may be combined with a test for persistent infection, but we are currently focusing on the sort of incipient TB test concept. So in the evaluation of a new test can sort of conceptually go through three different stages. The first is analytical evaluation, which is evaluation of different different subsets of well-characterized bank samples, basically a sort of proof of principle, if you will, a sort of phase one. Two is the clinical evaluation, in which the test is evaluated in the intended target population, and that's usually done in a controlled setting with high quality standards, and it is important there to evaluate the new test against a reference standard. And then the third, which you could think of in terms of if you compare to drug development, you could even think about it in terms of phase 4 trials. It's the evaluation for health or public health impact, which evaluates the test under routine conditions for impact on patient-important or health system-important outcomes. And it is important to note that comparison against a reference standard would not be necessary here. You just look at what the outcomes are. We will talk about these outcomes in a minute. And the document concentrates on these two phases because the first phase is very technical, and this is basically for the test manufacturers. And we didn't think that there would be an awful lot of guidance needed here. So this stage 2, the clinical evaluation stage. If we think of what sort of evidence would be needed, it is important, again, to note that for targeting preventive treatment, we are not interested in latent TB infection as such, but in predicting disease, which means that WHO endorsement should be ultimately be based on prediction of TB disease. And that means that some designs that have been used in the evaluation of IGRA will be non-informative for this decision process. For example, studies that compare test results with that of IGRA for a new test or with tuberculin skin test as the reference standard. It can perhaps be done in very early stages, but it's not the kind of evidence that you would need for endorsement. Another one is studies that analyze test results along a exposure gradient of to Mycobacterium tuberculosis. Many of the Icarus studies have actually looked at that. And it's not informative with regard to whether in the end tuberculosis will occur. Cross-sectional studies, so studies without follow-up for that same reason, are also non-informative. So the research questions for clinical evaluation, I'm sorry there's an awful lot of text on this slide. The purpose is to establish the predictive ability of the test in the absence of preventive treatment. So we want to know what happens if a test is positive or negative. We follow the individuals up without doing anything. And the main research questions would then be: 1, what is the accuracy in terms of sensitivity and specificity of the test to predict incident active TB within a specified period? 2, what is the positive and negative predictive value of that test for incident active TB within that specified period, and what is the corresponding number needed to screen to find one positive test, which we abbreviate as the NNS, and the number needed to treat to prevent one incident case, the NNT. And then what is the incidence rate of active TB after a positive test? What is the incidence rate after a negative test? And what is the corresponding incidence rate ratio? Now, if you think about what sort of the key questions or the key issues are, is that the test should be positive as much as possible in those who develop active TB over this period of 12 to 18 months, and it should be negative in persons who remain without active TB. So this is sort of our basic design. So a design should be a follow-up study of patients with high likelihood of recent exposure or otherwise high risk of developing TB. This is for reason of study efficiency, otherwise we would need far too big numbers. That addresses these two questions. And then we have basically two options. We have cohort designs or nested case control designs. So a cohort design is basically very simply this. So we test individuals, we follow them up, and we count the number of incident tuberculosis cases among those who are negative and compare them to those who are positive over a period of 12 to 18 months. And this is in a cohort, as always in a cohort study, with active ascertainment of incident TB stratified by these test results. There are a number of essential requirements, but they're no different from the requirements for any other cohort study, observational study. The probability of being included as a TB case should be independent of the test results, which means that case ascertainment should be blinded with regard to that result. And TB diagnosis should have high specificity, because if you have an incomplete specificity, you will have bias in your incidence rate ratio, so basically in your effect. Whereas if you have incomplete sensitivity, that doesn't really matter in terms of bias. It has consequences for your sample size. You simply need bigger numbers, but it doesn't really bias your outcomes. There are a number of additional challenges, and we've listed them here, and they are literally from the document. So one is that it will be difficult to find populations who have been recently exposed, who have a high risk of developing TB disease, but do not get preventive therapy, because that's what we need. And in these, you will get 4 slides which have the same format, and we will look at whether this problem occurs in low incidence settings, countries, whether it occurs in high incidence countries, what the potential effect of the problem is, and what sort of mitigation strategies we can think of. And so with the use of preventive therapy, this is something that will be present in low incidence countries for the majority of suitable study population, because that is current policy, those are current guidelines. In high incidence countries, it will be true for some, but not for all. Potential effects will be if we include persons who get preventive therapy, it will bias our accuracy estimates. And if we don't include them, it will limit our numbers of persons who can be enrolled. So what kind of mitigation strategies would we have? We could choose a study population in which IPT is not given for some sort of reason, for example, context of MDR patients, people who are ineligible per country guidelines, people who decline isoniazid preventive therapy, who are non-adherent. Now mind, these may cause all sorts of biases, so this is really where we have to think very hard about the consequences of these kind of choices. An alternative would be to include individuals who have been assigned to non-intervention arms in randomized controlled trials, in which you have much less of that bias problem. But of course, these are sort of populations that are harder to find. For example, TB preventive therapy trials or post-exposure vaccination trials, which are actually currently starting. And then finally, we could actually think of an RCT that is directly done for this question and compares an old versus a new test and strategy, but which would then include a reference standard. We will come back to that later. A second problem will be that the follow-up time can be pretty long. This would be true regardless of where we would do this study. A potential effect is basically long study duration, cohort attrition, so all sorts of problems. And then it says here, discussed above, but it's actually, you will get it as the fourth one, there is a larger potential for reinfection. So what can we do about it? We can try shorter follow-up, for example, only 12 months, or analyze by period of follow-up. Or, and that's the second one, I won't go into detail, that's an analytical issue. A third problem can be the still low progression rate, which will be true wherever we do it. We need a large sample size, so basically it's a matter of focusing on the highest risk group. So this is not rocket science at all. But this is a complex one. So how do we deal with reinfection? Because we know, especially if these kind of studies will be done in high incidence settings, where we know that there is a lot of reinfection, how do we deal with it? Now, if you think about it, and if you model it, you can see that reinfection biases the estimates that you get out of your study. So it underestimates the sensitivity. So the sensitivity will be lowered compared to what's the true sensitivity. It has no effect on the specificity. It will underestimate the negative predictive value, and it will, to some extent, overestimate the positive predictive value. You may think, how can that be if the specificity is not affected? And that is because the sensitivity is greatly affected. So this is a little bit of an effect. So you get a bit of overestimating of your positive predictive value. So how can we deal with that? So we can use shorter follow-up periods in which we expect less reinfection to occur, or we can focus on populations with low risk of exposure to ongoing transmission in a community, for example, young children, but those may be very difficult populations to study. So this is probably a problem that we will be stuck with and that we will have to think cleverly about, and it's probably more in the analysis stage that we can somehow adjust for that. And this is also to sort of sensitize any expert group that will decide on this, that this is something that needs to be thought about. And also means that we would love to see an expert group with a couple of brilliant statisticians in it. So the alternative here for clinical evaluation is a nested case control design, which is more or less the same thing, but what you do is that you test, you have negatives and positives, and the follow-up is done passively. So it's a passive cohort. At the end, you start off with the incident TB cases, and you look at their test status in a case control fashion within that. So the requirements are basically the same as for cohort studies. The nice thing about it is that it is much easier to get large sample sizes. The problem, however, is that you will have incomplete case ascertainment because it's done passively. So there is a trade-off again with the sample size. But it's something that could in principle be done. For clinical evaluation studies, it's important to distinguish a couple of subgroups for which we would need either through separate studies or through subgroup analyses, additional or relatively precise data. For example, people who have been treated before for TB, children, men versus women, those who have been BCG vaccinated again, compared to those who have not, and very importantly, those who have comorbidity, particularly HIV, but also diabetes, potentially malnutrition. So now let's go to the last phase, which is about public health or health impact. So again, about the admissible evidence. Now, the important thing to realize here is that a new test may identify the same absolute number of persons. So it can be just as sensitive as the current test that we have. Especially for an incipient TB test, sensitivity is probably lower. Well, at least for, well, no, ideally it's the same, sorry. Sensitivity is the same. The problem is that because the specificity is better and the PPV is better, you will in the end find fewer, you find in the end the same number of cases. So if you only look at the number of cases, then what is the comparison? So that means that the comparison needs to take into account some sort of cost-benefit endpoint, because what you get better bang for your buck. And that is in terms of not only in terms of monetary costs, as you see the list below there, like health system cost and patient monetary cost, but also in additional cost, some things that may be difficult to sort of cost in monetary terms, such as adverse events. So this is a very busy slide. I'm not going into all of these details. You can read them. The important thing here is to be aware what the purpose is of doing these kind of questions is to assess the impact of the assay on patient-reported outcomes and its public health impact when it's used to guide preventive treatment decisions. So preventive treatment is part of the game here. And that, of course, under routine conditions. And you can look at there's a whole list of questions which are basically about all these things around patient benefit, health service benefit, cost effectiveness. So the key questions here are, one, does the test, when it is used in routine settings, improve health outcomes? And does the test, when it is used in routine settings, improve cost effectiveness? And then a design is ideally a comparative design. Of course, we can do additional things like modeling, but in the end, we need, I think, comparative designs, ideally randomized. Can be individual randomization, group randomization. And we came up with two possibilities here. One is a design that would randomize individuals with a positive test. So you start off with a positive test and then randomize them for treatment versus no treatment. And the second one is to randomize individuals upfront for old test versus new test strategy and treatment. And the difference is in the study groups in which it can be used. So this we actually copied from this is the Cortes study design, which is the study that is actually meant to test this same 16-gene messenger RNA test that has been alluded to already. And I think it's a very good design. So this randomizes individuals with a positive test. So we do the new test, we randomize those who have a positive test, compare them to those who have a negative test, those who are randomized to preventive treatment or no preventive treatment, and then we look at the incident TB cases and all these other things. So these study outcomes, they refer to this complete set. So we look at the different in incident cases and sensitivity, specificity, and so on, but we will also look at the number needed to screen, number needed to treat, cost, and cost effectiveness. So, and it could actually be a bit longer than just those 18 months, maybe 2 years. So this is design number one. This is the kind of design that can be done in target groups that are currently not eligible for preventive treatment. Because we introduce a new test whereas there is no old test. There is no standard of care to which it is being compared. Whereas here, this is a design that could be used in target groups for which preventive treatment is currently indicated. So there is a standard of care. So this is the old test. So we randomize individuals or groups to old test versus new test. And in both cases, if the test is positive, preventive treatment is given. If not, it is not given. And we do the same kind of comparisons at the end. So, in conclusion, what we're looking for, at least in this document, is a test for incipient TB that requires a different evaluation approach than has been used for IGRA thus far. Endorsement should ultimately be based on the predictive power of to detect or predict incident TB, which means we need follow-up studies. Cohort studies with relatively short follow-up are needed for clinical evaluation, 12 to 18 months. Nested case control studies may be a useful alternative. Randomized control trials are ideally done to show impact on patient and health system important